Moving mark, perfect.
Yes, ma'am.
Okay,
Thank you. Zoom. Stop sharing this. Wait.
Network connections stable.
Yes, ma'am.
Yes, ma'am.
Minus பண்ணி.
ഇത് ഞാനൊരു വെബിനാറല്ല, പിന്നെ വിളിക്കാം.
அதே சம்பந்தியோட திருப்பி கல்யாணம் பண்ண ஆபீஸ்ல இருக்குது பொண்ணு இல்ல நம்ம இந்த மாதிரி எல்லாம் கண்ணாமண்ணான்னு பேச ரெஸ்பெக்ட் போயிட்டு அதாவது ஒரு மியூச்சுவல் ரெஸ்பெக்ட் போயிருக்கு.
Prasna sir, good evening sir.
Good evening, madam.
வேற விஷயம் இப்ப பொறுத்த வரைக்கும் லாஸ்ட் கம்ப்ளீட் அடிமை மாதிரி தான் சம்பந்தி கிட்ட இப்ப நம்மளாம் இருக்கிற மாதிரிலாம் நம்ம பேச அதான் சொல்றேன்.
I think you have to mute all.
Yes sir. Actually, Thiru sir is the host now sir. Once he changes me to host or yourself or myself.
Thirumurugan sir is the host now because of this. We'll have to individually, we cannot mute anybody. We are requesting.
Yes sir, yes ma'am. Only host.
Now you have become the host, Kritika.
Yes ma'am, I'll do.
Good evening.
Sir, good evening sir.
Good evening, sir. Somasundaram, sir. Good evening, sir.
Good evening, Prasanna. Good evening,
Good evening, madam.
sir.
Good evening, ma'am. Good evening, everyone.
Paldi sir, good evening.
Good evening, everyone.
Paidi sir, the host, co-host akidunga, Kritika.
Okay ma'am.
Sulfikar sir, good evening sir.
Yeah, good evening. Somasundaram, how are you?
Good sir. Thank you for joining us in spite of your busy schedule. So all our postgraduates will be benefited with
like your postgraduate, I had a sore throat. So both of us are improved, recovered.
Okay. Thank you sir. Thank you.
Madam, PG has joined, madam. Brinda has joined. Yes, ma'am.
Maniram Kumar. SPS.
Sir, we have checked Brinda's slides too. Their slides are moving and they are perfect, sir. I'll call Maniram sir now, sir.
Yeah.
Good evening, everyone.
Good evening.
Good evening.
Good evening and welcome.
Palliram sir, welcome.
Good evening, boss.
Good evening,
boss.
Good evening, Dr. Pania sir. Padiram sir.
Very good evening.
Paniram sir has joined. We can start the program. Everybody has joined. So before I think Paniraman sir will talk, we will start the program. It's 8:32.
Okay.
Yeah.
Okay, ma'am. Okay, ma'am. I have informed SPS sir. Sir will be joining shortly.
Okay. So shall we start the program, Kritika?
Yes.
Sir will be joining shortly.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am.
Okay.
Good evening, everyone.
Sir, good evening. Namrata, SPS sir has to join, no?
Sir, I had called sir. Sir will be joining shortly. I have informed him.
Maniram Kumar.
Maniram sir, yes, sir. I had called them, both of them. Sir also will be joining shortly. I'll call Maniram sir again, sir.
We'll wait for 1 or 2 minutes, no? Let them join and then we can start. No?
Okay, sir. Okay. Sir.
Can we start, Somasundram? I think by the time we finish the inaugural and all that, they will all join together. And anyway, Paniraman sir's talk is also there.
Okay.
Maniram sir has joined.
SBS sir joined. That link he had was an older link. He's joining in a minute.
Good evening, everybody, to all the elite people who have joined us on the stage and to the budding postgraduates who want to learn from the masters. Welcome to the second edition of Virtual Gurukulam. We are very happy to invite you here. We will start with the pediatrician's prayer. Dr. Rajkumar, I'm not seeing. Dr. Rajkumar? Okay.
நாளைக்கு உங்களால முடியும்னா வாங்கோ நான் எனக்கு ஒண்ணும் பிரச்சனை.
Kritika, can you mute everybody?
Yes, ma'am.
Yeah. Yeah.
Sir, welcome SPS sir.
Welcome, sir. Balasubramanian sir.
Good evening, sir. Good evening, sir.
We'll start with the
Good evening,
pediatrician's
sir.
prayer. Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with ability to alleviate suffering. May we be emissaries of health, learning, charity, love and peace to all children and their families, irrespective of status and creed. Give us the wisdom, understanding to change the things we can, retain the good and accept within reason the things we cannot change. Grant us your blessings, grace and mercy in all situations, at all times and amidst all people. Hello everybody, I am Dr. Narmada, Honorary Secretary of IAP Tamil Nadu State Chapter. We welcome all the postgraduates who have joined here as well as the delegates on the dais. Now I request Dr. Somasundram, President, Indian Academy of Pediatrics Tamil Nadu State Chapter, to give the welcome presidential address. You have to unmute yourself, Somasundram.
Dr. Narmada and welcome. So this is the second edition or the second session of the postgraduate teaching program, which is christened as Virtual Gurukulam 2.0 under the Presidential Action Plan of IAP Tamil Nadu State Chapter. For the second session, we have two parts of the session. The first part will be for 15 minutes on CBC by our well-known faculty, Dr. Panniraman sir. Moving on to the second session, we have two eminent faculties, the renowned senior most cardiologist from Trivandrum Medical College, Dr. Zulfikar Ahmed sir. Sir, welcome you sir on behalf of IAP Tamil Nadu State Chapter. We are very honored to have you here and your knowledge and wisdom will be very useful for the postgraduates of our states. So, sir, a few words of introduction about sir. Sir is a senior consultant in pediatric cardiology at KIMS Health, Trivandrum, Kerala. Former HOD, pediatric cardiology, Government Medical College, Trivandrum, and he is the former chairperson of the IAP cardiology chapter, national and the state. Editor of the IAP textbook of pediatric cardiology 2022. Section co-editor of cardiology in PG textbook of pediatrics. Co-editor of IAP textbook of radiology. Sir has got special interest in CHD, echocardiography of CHD, rheumatic fever, Kawasaki disease, and preventive cardiology. So, as this session is on rheumatic fever, I have read about you. I have read and attended your classes on rheumatic fever, sir. So, definitely your expertise will be very useful for all of us. Already 65, 66 people are on Zoom, and about 30 people are on YouTube to hear with this and few more are joining, sir. Welcome you on behalf of IAP TNSC. Then we have Dr. Maniram Kumar. Maniram Kumar will be introduced by Dr. Prasanna.
Yes,
Yes,
sir.
sir.
Yeah, and Maniram Kumar is also a budding cardiologist from Tanjavur. So he's the son of our president-elect, Dr. Singarvelu, sir. Welcome, Dr. Ram Kumar. And we have our own office bearers, Dr. T.N. Manogar, sir, who is the academic coordinator, Vishwanathan, who is the vice president. And all our programs are complemented by the knowledge of our scientific advisor, Dr. S. Balasubramaniam, sir, who is with us for the past 14 months to enlighten the postgraduates. Welcome you, SPS, sir, on behalf of IAP Tamil Nadu State Chapter once again for the second session of postgraduate teaching. Over to Dr. Narmada. Welcome all the postgraduates too who have joined on this platform and all the practitioners. Over to Narmada.
Thank you so much, Dr. Somasundram. Now we have our coordinator, Academy of Pediatric Sciences, Academic Coordinator, Dr. T.N. Manovar, sir, to say a few words and then we'll hand over the session. Sir, over to you.
Already, Dr. Palani Raman and others have been introduced. Dr. Palani Raman, actually, he has all the gadgets than anyone else in the country can have in his clinic. And he is a specialist in every field. That's what I think. He has such a wide knowledge and is a very good photographer. Let us learn from him what we can decipher from CBC and what are the limitations of CBC. That's one. The second session will be by Dr. Zulfikar Ahmed, a renowned cardiologist, a doyen in his field, and his aim is to empower next generation. And he has so many videos, educative videos to his credit. His aim is to empower the juniors. And also, we have another young budding cardiologist, Dr. Maniram Kumar, who is a gold medalist as a postgraduate, and he had an outstanding career as a DM cardiology while doing DM cardiology at Amrita Institute, and he also had training at Australia. Now we'll have happy learning from all these great persons. Over to you, Dr. Narmada.
Thank you so much, Dr. Manohar, sir. I request Dr. Balasubramaniam, sir, our coordinator for the entire postgraduate program and our teacher to start the program with his kind words.
Yeah, I do not want to waste the
Welcome.
in fact, more than the students, it's me who's more eager to listen to my good friend, Dr.
Really.
I'm an admirer of him for the last 4 decades. We enjoy very good rapport, and of course, Maniram Krishna was the best outgoing student and the gold medalist from Child Stress, and he was the one who published our paper on Kawasaki in Indian Pediatrics 15 years back. And in fact, Dr. Narmada said he is a budding cardiologist. He's no more a budding cardiologist.
He's already an established one.
He's a full-blown cardiologist now. Okay, I look forward to listening from the young took as well as the veteran. Thank you very much.
Thank you so much, sir. Now I hand over the stage to the coordinators of this program, Dr. Prasanna and Kritika, for further proceedings while we are all waiting eagerly to listen to the experts. Over to you both of you.
Thank you, madam. Kritika, can you start the proceedings?
Yes, sir. Respected Somasundram, sir, Narmada ma'am, Rajkumar, sir, Thiru, sir, Singarvelu, sir, scientific advisor, SBS sir, respected eminent faculties today, Zulfikar sir and Maniram sir and Palni Raman sir, dear students, very good evening to all of you. And without further ado, I hand over the stage to Palni Raman sir. Sir, we are very eager to learn then what's new in CBC from you. Can you please share your slides, sir?
Yeah, okay.
Yes, sir. Slides are visible, sir.
Am I audible now?
Yes, sir.
Yes, yes.
We can, yes, sir.
Very clear.
Okay. Very good evening, my dear colleagues. First of all, I thank the office bearers of IAP TNSC as well as the Academy Virtual Gurukulam coordinators Kritika and Prasanna Raju, and my dearest senior person, Dr. SBS sir, who is always guiding force behind me, and TN Manohar, my close friend and thing. And to start with, now we'll start the topic decoding the pediatric CBC by a practitioner for practitioners as well as for the postgraduates. To disclaimer, I'm not a hematologist. I'm a general pediatrician with special interest in hematology. And nowadays, the CBC is considered as a sixth vital sign, even though it is not so, because it is almost affordable, accessible, available every nook and corner. Whenever a patient is uncovered in an OPD or anywhere, immediately when you don't know anything, immediately you look at the CBC as though CBC is going to give all the answers. But it has a lot of limitations. Let us see how we can decode the CBC. And we all know pediatric is a dynamic, it is a age-dependent norms are there, and it is not like adult, not a mini adult. Do not misinterpret physiological changes as pathological. This is very, very important. We should understand at what age what is normal. For example, in a newborn, the hemoglobin of 16 to 18 is normal. Any hemoglobin less than 12 is anemia in a newborn age. And in the same way, MCV in the newborn is more than 100. But the infant and childhood age group, the normal hemoglobin cutoff is 11 grams and MCV is 70 to 90. And this age is mainly the predominance of lymphocytes are there. Whereas in the adolescence, the hemoglobin cutoff is less than 13 and the MCV is like an adult 80 to 100 or 80 to 95 and the predominance of neutrophils. In the same way, the WBC also has a pattern. In the first 2 weeks, the neutrophils predominates. After 2 weeks, around the lymphocytes predominates over the neutrophil. From 2 weeks to 6 years, the lymphocyte predominance, and followed by 6 years, actually the crossover happens and finally the neutrophils take over, and finally neutrophils is the predominant cells in the adults and adolescents. This is the normal dynamic age-dependent norm of CBC. This has to be, one has to be keep in mind before interpreting first slide. Next, whenever you are decoding any numbers, you should know what is the cutoff. For example, whenever the total count be actually, what is the total count? When do you say leukocytosis? Only when it is more than 15,000, we say leukocytosis in pediatrics. In adults, it is more than 11,000. So, and when do you say neutrophilic leukocytosis? When the total count is high and neutrophils are high and it is more than 10,000. In the same way, lymphocytosis. Because why this slide is important? Because plenty of times we come across the normal count 5 to 15,000. That is a 7,000, 8,000 total count and neutrophils 80%, and it is considered as a neutrophilia and started on a bacterial infection. So only we should know when to say is as a neutrophilic leukocytosis and lymphocytic leukocytosis. This is a very, very important slide. One should know when to say abnormal. And second thing, in the same way, the leukopenia also, we should know what is the cutoff, less than 4,000. It can be a neutropenic or a lymphopenic, but very, very important, always see what is happening in the other cell lines. When the HB is less than 10 grams, considered as anemia for all practical purposes, and platelets is less than 1 lakh, considered as a thrombocytopenia for all practical purposes. When you should see all the cell lines, what is happening. Okay. Now let us go. This lecture is going to be first 5 to 7 minutes for how the CBC is utilized in the field of infections, and second in the field of hematology. We left and right use the CBC for mainly the infections, as though it diagnoses all the infections. And particularly in a fever without focus, CBC gives the direction, not the diagnosis. And what is the timing should CBC do a CBC? First 48 hours, always avoid doing CBC. It can be a stress phenomenon. Only if it is, the timing is only if it is more than 48 to 72 hours, one should look at the CBC if you are not able to come to a conclusion clinically. And whenever there is a neutrophilic leukocytosis or a leukopenia, what should be our action? Let us see in the further slides. This is now day 3. First 2 days, we are not going to do anything. Day 3, fever 3 days, high neutrophils, no clinical focus. You should always hunt for occult infection. Gone are the days of hunting for occult bacteremia. Now, after pneumococcal vaccination and Hib vaccination, occult bacteria is out of the syllabus. Now, only 2 occult are there. In a pre-verbal child, always rule out occult UTI, always check urine. Even if his CBC is normal, do urine test. Second thing, after ruling out UTI, the second most important thing is occult pneumonia. If fever is more than 39 or 102, WBC more than 20,000, always take it's a dictum to take a chest X-ray. You will be rewarded in 30%. You can have pneumonia
medical
even
shop
without
lo, mana medical shop lo.
And finally, if the hello. And finally, if the CBC, if you do on day 5 or not, and if there is neutrophilic leukocytosis, after ruling all the conventional bacterial infection like UTI, pneumonia, skeletal infection, occult abscess, think beyond infection, think about Kawasaki or a systemic onset JIA. What is the important clinical take-home message at this point? High count is not equal to immediate ceftriaxone. Neutrophilia indicates only inflammation, not necessarily a bacterial need for broad spectrum antibiotics. Find the focus first. Even an adenoviral infection can cause this. So it is not always equal to bacterial infection, number 1. Number 2, when you come across lymphocytic leukocytosis, how to interpret? It can be a viral infection or a sinister infection. Whenever the total count is high, lymphocytes are high. When other cell lines are completely normal, HB is normal or platelets are normal, think about common, that is infectious lymphocytosis produced by Coxsackie and echovirus. They can produce high counts and high lymphocytes where other cell lines are normal. Whereas if the hemoglobin is abnormal or platelets are abnormal, always suspect something is going wrong. If there are atypical lymphocytes and other things are there, it can be infectious mononucleosis, or if there are blasts, anything, you can suspect a malignancy. So always when other cell lines are normal, your red antenna should be high. It is not a simple lymphocytosis. It should be always malignancy should be at the back of the mind. Okay, coming to the leukopenia. It is a tropical signal. During monsoon season, you should think about mainly whenever the fever crosses 3rd day, 4th day, all the tropical infections come to the picture. So all the tropical infections cause leukopenia. And whether viral tropical infection or a bacterial tropical infection, it causes leukopenia. That is the dictum. And particularly, they along with the leukopenia, they also cause thrombocytopenia. Depending upon the timing of leukopenia and thrombocytopenia, and you can easily come to a conclusion whether I am dealing with a dengue or a malaria or a typhoid or typhus. This is only gives the probability, most probability. For example, when the triad of leukopenia, thrombocytopenia, high hematocrit is mostly this diagnostic triad is not found in anything. You confirm by dengue NS1, so dengue triad. And when there is a leukopenia, thrombocytopenia, and anemia with monocyte, it can be a malaria confirmed with peripheral smear. If there is, particularly during the 2nd week, if there is leukopenia and thrombocytopenia, think about typhoid or scrub typhus and confirm by blood culture or IgM ELISA for scrub. So this is the way one should try to evaluate whenever you come across fever without focus. When the counts are high or counts are low, when the counts are normal, it doesn't mean anything to you. It can be useful only as a baseline. So this is the managing finally flow chart. This would have seen already many times. Whenever there is no focus and if you are first 48 hours wait, you do the CBC. If there is neutrophilia, think about pyelonephritis, pneumonia, and beyond day 5, think about mainly the occult abscess or Kawasaki. If there are lymphocytosis, if the other cell lines are normal, it can be a reactive viral. If there is a leukopenia, tropical workup, as I have already told. That's all so far. Hope you would have able to, that is, decode how to interpret the CBC for a practicing postgraduate as well as for a practicing physician when they come across a fever without focus in day-to-day practice. This will be very useful. This flowchart, kindly take a screenshot of this. Now, let us go to the second part, hematology. Here, the CBC gives the diagnosis. Normally, patient won't come with the pallor or bleeding. When they come with the pallor or bleeding, naturally, CBC is going to actually cult the diagnosis. That is the specialty, unlike infections where it gives the direction. And whenever you come across a pale child, when the hemoglobin is low, your eye should go for MCV and RDW. This triad, hemoglobin, MCV, RDW, this matrix can easily come and give the diagnosis of iron deficiency, nutritional B12, megaloblastic anemia, thalcrate, marrow failure, easily by the thing. Let us see how it thinks. Whenever you come across a microcytic anemia, low MCV, less than 70 or 75, it can be iron deficiency or thalassemia. In case of iron deficiency, RDW will be very high. It will be more than 15, 20, 22, and usually platelet will be high. So this is the iron deficiency. Whereas in case of thal minor, actually the RDW will be normal with microcytosis, but one catch is the RBC count will be very high. Unlike iron deficiency, RBC count will be low. So only we will go about with the Menser index. Menser index is low in thal minor and high in iron deficiency. What about thal major? Everybody think even in thal major, the RDW will be normal. It is not so. It has the highest RDW because it is a dirty smear containing all sorts of cells. Small cell, large cell, reticulocyte, target cell. So in a thal major, the RDW will be highest. So microcytic anemia with the highest RDW, with the hepatosplenomegaly, you always think about all nutritional anemias will not have hepatosplenomegaly like thal minor also. So this is the with respect to microcytic anemia. So in short, this is the very good flow chart. Microcytic anemia, low MCV, check RDW, high iron deficiency, normal RDW, check the RBC count. If it is high, thal minor. If it is normal or low, anemia of chronic disease and lead poisoning. This is a very good flow chart for microcytic anemia. Coming to the macrocytic and normocytic patterns. Here what happens? Even here again apply the same rule, MCV and RDW. High MCV, high RDW, usually megaloblastic anemia, nutritional anemia. So high RDW is a good for a practicing person. Whenever the RDW is normal, always refer to a hematologist. It is some sinister cause. For example, high MCV with the normal RDW, it can be aplastic anemia or bone marrow failure. Check for pancytopenia. So, okay, I have told about microcytic, low MCV, I have told about high MCV. What about normal MCV? Whenever there is a normal MCV, our eyes should go immediately to go for MCHC. If the MCHC is very high, more than 35, immediately see to that clinically the child is having jaundice and splenomegaly. It clinches the diagnosis that you are dealing with a case of hereditary spherocytosis. In 50% of the time, you can clinch the diagnosis with a simple MCHC. So this is the way that whenever the normal MCV is there. And moreover, whenever you have a macrocytic and normocytic pattern, always go for the reticulocyte count. This is a very, very important. Apart from RDW, retic count gives a clue whether the marrow is a functioning marrow or a marrow is a overprotective marrow. Whereas in case of B12 deficiency, the marrow will be particularly have a low reticulocyte count in aplastic anemia and a suppression low retic count. Whereas in case of this is an acute and you should go for the corrected retic count because otherwise it can lead to erroneous results. So I have already introduced MCV, RDW. In the same way, I am introducing another word MPV, like a mean corpuscular volume for red cell, MPV for platelets. Whenever there is a platelet cells or numbers are low, look at the MPV. If the MPV is high, it indicates mostly it is a peripheral destruction with the producing bone marrow producing large platelets. You can see large platelets in the left. It indicates mostly immune thrombocytopenia. Whereas if the platelets are very small, it indicates there is a bone marrow is not producing. It can be aplastic or it can be viscotolbridge, anything. So in the same way, MPV is useful. So after this, I am going to introduce the next important thing to the word, that is absolute neutrophil count. Whenever you see a CBC, when you are dealing with a patient with a prolonged fever or a paler child or a bleeding child, you should always calculate the absolute neutrophil count. Why? Because this pseudo lymphocytosis can mask the neutropenia or apparent lymphocytes. For example, the total count will be 7,000 and the lymphocytes be 90%. You think there is lymphocytosis. It is not so. Where the 10% of the neutrophils, when you calculate, it will come less than 1,000. If the ANC is less than 1,000 in a child with anemia or bone pain, always suspected it is a problem with the bone marrow. When the ANC is the best indicator of the marrow function. So whenever the ANC is low, you try to calculate, definitely it indicates you are dealing with a case of mostly a case of ALL or whatever the thing, some sinister causes like leukemia. So immediate action should be peripheral smear. So final thing, important truth is, with respect to hematology, the CBC is incomplete without the peripheral smear. The peripheral smear gives the morphological diagnosis in front of your eyes. You can see hereditary spherocytosis, confirm the thing, confirm the CBC finding. You can see the HUS, you can see thalassemia, you can see megaloblastic anemia, you can see blast in case of leukemia with the help of the smear, everything. And finally, not but the least, the next word I am introducing is absolute lymphocyte count. Whenever there are recurrent infant deaths, and when you see in the family, running in the family, you take the cord blood or early infantile stage, you do this absolute lymphocyte count. If it is less than 3,000, for example, total count is around 7 or 8,000. If the total lymphocytes are only 10%, if the lymphocyte count is less than 3,000, suspect a severe combined immunodeficiency. This is very, very important whenever you in a early infancy with a recurrent infant deaths. So the essentials of CBC are MCV, RDW, MCHC, MPP, ANC, ALC. These are the very basic things. Whenever you see a CBC, when you try to calculate all the things will give the diagnosis from iron deficiency to megaloblastic anemia to hereditary spherocytosis plus ITP to leukemia to SCID. All the things can be diagnosed with these essentials of the CBC. And so to conclude, in hematology, the CBC along with the smear study, it is a high utility value. It is really diagnostic. CBC is diagnostic. Whereas with respect to infections, with respect to dengue, it is useful in diagnosis and further management. Whereas coming to the routine infections, it gives a direction. Be cautious interpretation is required with coming to trap of the routine infection. Utilize CBC as a starting point for further evaluation. Thank you very much.
Thank you so much, sir, for that lucid and absolutely fantastic presentation. There are so many things to learn from Palniraman, sir. But the one thing is, stay updated always. Sir is into the AI now, I think. Sir, your slides are awesome.
Thank you very much, madam. Actually, the content is mine, creativity is by okay, thank you.
Thank you so much, sir. Thank you so
Creativity
much.
is by notebook LLM. Okay.
Yes, sir. Yes, sir. Yes, sir. Superb, sir. Superb slides. Do we have any questions or doubts?
Just one brief question to Dr. Palniraman, Kritika.
Yes, sir, please. Yes, sir, please.
Dr. Palniraman, just sometimes we do see, a neutropenia for 1 or 2 days, 3 days duration. Can it be normal when a child is looking well, but we do come across neutropenia sometimes, for a few days? How not to worry in those patients?
Actually, commonly when you have short duration fever, you come across the bone marrow suppression and neutropenia, which is very common in viral illness with lymphocytosis. When the persistence of the neutropenia is more important than the transient neutropenia. This transient thing up to 10 days is normal. No need to give importance to this.
When the absolute neutrophil count less than 1,000, you can wait?
Yeah, we can definitely wait. If it is the short history and short fever, you can wait.
Thank you. Thank you.
Thank you so much, Palniraman, sir. Whenever the word CBC comes to my mind, it is you who comes to all of us mind. Excellent, and hats off to you, sir.
Thank you. Thank you very much for that, for giving me the opportunity. Thank you, SPS sir. Anything because you are against CBC because clinical thing you always
No. When Tendulkar is batting, others have to only watch and enjoy. Fantastic. I think in fact, in a lighter vein, I think Palniraman would agree. These numbers don't matter. Numbers. Okay. Always interpret the numbers along with your clinical judgment. One. In general, lower the counts, more sinister the problem is likely to be. Third, we pediatricians, we worry about high counts rather than low counts. For example, Dr. Palniraman rightly put, I myself have missed SCID by failing to note the low lymphocyte count. It is there. The diagnosis is there, but we often, of course, we picked up the diagnosis a few days later. So lymphopenia is often omitted by pediatricians. Pediatricians worry more about lymphocytosis, neutrophilic leukocytosis. And though Viswanathan sir pointed out the sinisterness of neutropenia, I think neutropenia is something which can be dangerous. If you find neutropenia, even if it is short duration fever, absolute neutrophil count less than 1,000, it is better to repeat at least after a week or two after the child recovers, so that you don't miss something like cyclic neutropenia or a chronic immunodeficiency or some bone marrow failure syndromes. These are my comments. Otherwise, it was brilliant, Dr. Paniraman. I envy you not only for your subject, but also for your technical brilliant science.
Thank you, sir. Thank you,
Thank
Ananda.
you.
Thank you.
Thank you so much for the words of wisdom, sir. So we are into the second session now, and to learn a case discussion on cardiology under the mentorship of Dr. Vasantha Malar, we have students from our own institute, Government Teni Medical College, Dr. Brenda, and to guide them, we do have two eminent faculties, Zulfikar sir and Maniram sir. They have already been introduced. So, sir, Zulfikar sir, Maniram sir, shall I ask the postgraduate to share the slides?
Yeah, please.
Okay, sir.
Maniram, how are you?
Good, sir. Good, sir. How are you, sir?
I never knew the link, your link with Dr. Shingaravelu. Yeah.
Brenda, please share your slides, ma.
Yes, ma'am.
I request all the others to mute, please, except the faculties and the presenter. Can I ask everyone, every other to mute? Brenda, you can start presenting, ma.
Okay, ma'am. Good evening to all present here. I'm Dr. Brenda, postgraduate from Government Teni Medical College. I'm going to present a case. Shall I present her now?
Yes, ma. Yes, ma. Please go ahead.
Chief complaint. A 11-year-old boy, second born of non-consanguineous parents, studying 6th standard and hailing from Teni, was brought by his mother, whose relative is good, with chief complaints of joint pain for past 3 weeks. History of presenting illness. The child was apparently normal 4 weeks back.
May I have your pardon, please? Sir, faculty Zulfikar sir and Maniram sir, if Brenda finds it very difficult to present, can I ask Abhinaya to take over, sir?
Sure.
We have no problem.
Okay, sir.
Whichever is comfortable to people.
So I think Brenda will be anything, then I'll ask Abhinaya to take over. Thank you so much, sir.
Right.
The child was apparently normal 4 weeks back. History of pain in multiple joints for past 3 weeks. Initially started on right knee joint, not associated with swelling and redness. Pain is severe in nature, so that the child has difficulty in walking and moving. Child taken to nearby hospital, some IM injection were given. Pain gradually subsided over 3 days with no restriction of movement. After 4 days, child developed pain in left knee joint, no swelling and redness. Child is unable to move the limbs due to pain. Child taken to hospital again and had some IM injections. Pain subsided. Again after 3 days, the child had pain in left wrist joint, for which the child was taken to a hospital for further evaluation. Pain was migratory in nature, involving only large joints. No history of small joint involvement, no history of stiffness of joints. History of fever present 1 week prior to the onset of joint pain. Acute in onset, duration was 3 days, high grade, which was intermittent and not associated with children rigor. There is no aggravating factors and relieved with medications. No history of breathlessness on exertion, activity limitation, or no chest pain, no palpitation, no syncope. No history of easy fatigability, no history of orthopnea, and no history of parenchymal nocturnal dyspnea. No history of swelling of legs, no history of facial puffiness and reduced urine output. No history of involuntary movements and no history of behavioral changes. No history of rashes over the body, no history of swelling over the bony prominences. There is no history of bleeding manifestations or abdominal pain, no history of painful swelling over fingertips, and there was no history of cough, cold, vomiting, and loose stools. Shall I proceed, sir?
No, can you go back to the first slide? We will start over once again.
Oh, okay, sir.
Okay, and the questions probably will be asked to Abhinaya because of your sore throat. One more person is there, no, with you?
Yes, sir. Yes, sir.
Supporting class.
Yes,
Who is
sir.
that? Who is that person? What is the name?
Kirtika, sir, myself.
Okay. So it's an 11-year-old boy with next slide. Yeah. So Abhinaya, what
Yes,
does this slide convey to you?
it
In
is
one or two sentences, what is the problem?
actually
How
this is
old
an
is the child? 11-year-old
yes,
boy.
sir.
Yeah.
11 years old child who has been presented with multiple joint involvement, which was acute in onset, migratory in nature.
Yeah, as a medical person, what is your take?
Migratory polyarthralgia, sir.
Yes, it's basically an 11-year-old boy has got a migratory polyarthritis. Two terms are very important.
Yes, sir.
Polyarthritis is definitely there, and it is migratory. And what is the third important point which Brinda mentioned? No
Relieved,
history of
small joint involvement, sir.
no history of small joint involvement, right? Okay. So at this point, with a migratory or non-migratory, whatever may be, we have a polyarthritis in an 11-year-old child. What will be the first possibility in our country?
Rheumatic fever, sir.
Acute rheumatic fever is the most likely possibility. Okay. Then what else will you think of? 11-year-old boy. Polyarthritis.
Just one question, doctor. Is there something which is not fitting with the diagnosis of acute rheumatic fever here? So you say this is acute rheumatic fever. There is active inflammation going on. Is there something which is not fitting into the diagnosis here? Any point which is striking for you from this presentation?
Even without medication, it would have relieved, sir.
No. There is no fever at all. Okay.
Yes, sir.
So you say there was fever 1 week before this joint pain subsided.
Yes, sir.
Started. And it lasted for 3 days and then it stopped. So essentially, child was completely asymptomatic for a period before the joint involvement started, right?
Yes.
So if it is acute rheumatic fever, there's going to be ongoing inflammation, especially when the joints are so badly affected, so badly that he was not even able to walk.
Yes.
But he has had no fever at all. Don't you find that very surprising? Because when you sent me the presentation, that was the first thing which struck me. Okay. So I'm sure all of you would have seen rheumatic fever, right?
Yes.
So then during the arthralgia stage or the arthritis stage, they'll be having high grade fever. They'll be having tachycardia. And if cardiac involvement is there, they will definitely be breathless. So this is something which doesn't make sense to me at all. So what do you think is the reason for that? So is there something you missed probably on the history, or does this strike you as something which is not fitting into the diagnosis? Because you say this is acute rheumatic fever, but there's no fever at all, right?
Yes, sir.
That is one thing which I do not understand, doctor, from your history.
One point, one clarification is that, see, nowadays with the declining of rheumatic fever in South India, what is happening is that there is a sort of a polyarthralgia without much fever, but cardiac involvement. But here, as Maniram was saying, it basically has significant polyarthritis, but without fever. I think that is an unusual thing. So, but you must remember that there is a change of scenario in rheumatic fever these days, especially in our states, the combined states, that fever may not be a very prominent one. And secondly, you can always answer. See, for example, some injections were given.
Yes.
So would have been a painkiller. Painkiller means what? Paracetamol or maybe anti-inflammatory NSAIDs would have been given. Tablets have been given probably along with injections. So the fever probably would have been missed or suppressed by the use of either paracetamol or NSAID. That is why whenever we think of acute rheumatic fever, we should try to avoid NSAID because NSAID rapidly masks That is that's one point you can argue.
Prasanna, please mute others. Dr. Prasanna, there is some background noise. Mute everybody else.
That is one point. Otherwise, apart from that fever, I think more or less typical. But what are the other? Suppose basically you are presenting it as a cardiovascular case, so naturally I presume that this child has got some cardiac involvement. So come to the next slide. I want to ask you a few questions. Next slide. Yeah, history of fever present 1 week prior to the onset, high-grade chills and rigor, etc., etc. But what we were interested, or Dr. Maniraman and myself would be interested, would be in the history of a sore throat. See, fever 1 week prior to the onset of joint pain means would have been due to a streptococcal throat infection. So you have mentioned only intermittent fever, chills and rigor, etc. No aggravating factor, but you have not mentioned anything about a sore throat. That is another minor what you call as an omission, and relieved with the medication. Then you were saying history of breathlessness is not there, activity limitation is not there, chest pain, palpitation, etc. is not there. So basically, you are saying that at that particular point of time, there was no genuine suggestion of a significant cardiac involvement, right? Cardiac involvement. Okay. Now you said orthopnea and PND. No orthopnea, no PND. What is the importance of PND in an 11-year-old child with suspected rheumatic fever with or without cardiac involvement? What is physiologically the key to PND? Suppose somebody says, I am having PND, or you are saying that your patient is having PND. What do you convey to the others? What is the pathophysiology?
In paroxysmal nocturnal dyspnea, there will be after the patient will be lie down. After
that we know. We know the typical description of PND, but
yes.
What is the significance? Anybody can say. No,
basically
PND means
basically
it's a left heart
left
disease.
heart failure.
Any patient with a heart disease, myocardial disease or whatever disease, congenital heart disease, if there is a genuine PND, it means it predominantly affects the left side of the heart. That is the importance of PND. Whereas orthopnea can occur even without a cardiac problem sometimes. So PND is very, very specific to left heart disease. And rheumatic fever. In rheumatic fever, the most common valves involved are on the left side, mitral and as well as aortic valve. And there is no history of swelling, involuntary movements, naturally, behavioral changes, rashes over the body, swelling over bony prominences. Okay, next slide. And no history of painful swelling or fingertips. What do you look for? Why do you look for that?
Osler's notes.
In what? Which condition?
Infective endocarditis.
Infective endocarditis. But again, Manira will be very much surprised because you are thinking of infective endocarditis even without
fever.
Without fever.
Yes.
See, the point is, if you look at the presentation of infective endocarditis in children, 98 to 99% of them will have fever, documented fever. So practically, you cannot have an infective endocarditis without documented fever. But in rheumatic, even though we call it as acute rheumatic fever, sometimes, especially with the polyarthralgia presentation with the cardiac involvement dominating, then there may not be a significant degree of fever. So here, that was one. Probably, yeah, it's important because it can produce polyarthritis, cardiac involvement. I agree, right. Then you said about bleeding manifestations and abdominal pain. I find it very interesting. Why?
Atypical presentations of rheumatic.
Typical presentations of rheumatic fever, that is bleeding. From where?
Epistaxis.
Epistaxis and abdominal pain. Okay,
yes.
These are all basically the relics of the past. You don't see bleeding tendencies or epistaxis or abdominal pain. In this, we used to be taught that abdominal pain may be because of mesenteric lymphadenitis or a painful hepatic enlargement. But epistaxis, absolutely, there is no scientific, what you call as a rationale mentioned in textbooks on why there used to be epistaxis in the 1930s and 40s in rheumatic fever. Okay, right. Go ahead.
Okay, sir.
Shall I proceed, sir?
Maniram, shall we proceed?
Yes, sir. Yes, sir.
Past history, no similar complaints in the past, no previous admissions in the hospital, not a known case of congenital heart disease, tuberculosis, and bronchitis.
Why did you specifically choose tuberculosis and bronchial asthma, doctor? Like,
I was tempted, but I did not ask.
Any specific reason why you chose tuberculosis and bronchial asthma among all the diseases? CHD, I agree, you're presenting a heart case. Try to establish that there's no pre-existing heart disease, but tuberculosis arthritis. Because
in the examination,
there are no respiratory-related complaints in your patient from the present history. So why did you specifically choose tuberculosis and bronchial asthma among the disorders?
In the examination, at the last ditch battle to survive, you can say, I asked for tuberculosis because the child may be having a carditis, which will require steroids. So I wanted to contact with tuberculosis. That's all you can say. Otherwise, it would be better not to mention all these things.
Okay.
You can say there is definitely you can say no complaint, no history suggestive of a congenital heart disease, because this could be a congenital heart disease with infective endocarditis presenting as polyarthritis. It is possible, but usually smaller joints are more involved in infective endocarditis. It is not migratory in nature, and most of the time it will be arthralgia rather than genuine large joint arthritis. So this is less likely to be infective endocarditis. Now, at this point in the past history is over almost. Now, what are the other causes of polyarthritis in an 11-year-old child? We have only covered rheumatic fever. And secondly, infective endocarditis. What are the other conditions where you can have an adolescent with a polyarthritis, either migratory or non-migratory?
Juvenile
Anybody
idiopathic.
can answer. Abhinaya can answer.
Juvenile idiopathic arthritis.
You can have a juvenile idiopathic arthritis. Definitely, for the record, you should know in the examination, they will ask you the clinical differences between JIA and acute rheumatic fever. You should be able to say the comparisons. Okay,
Yes,
what else?
Reactive arthritis can happen, sir.
Reactive arthritis can occur, right? Then
SLE.
yes, collagen vascular disease like SLE is possible because SLE is one condition where you can have joint pain as well as heart involvement. Can you have heart involvement in JIA?
Yes, sir. Pericardial effusion can happen, sir.
Pericardial effusion can happen. Now, another very practical thing in JIA with cardiac involvement is that MR is also possible in JIA, but it is so rare to have MR without pericardial effusion in JIA.
Yes.
Similarly, it is so rare to have pericardial effusion without valvular involvement in rheumatic fever. You understood the difference, right?
Yes.
In JIA, you may have valvular involvement, but invariably associated with some degree of pericardial effusion. Whereas in rheumatic fever, there can be effusion, but invariably it will be associated with valvular. You cannot diagnose rheumatic pericardial effusion or pericarditis without concomitant valvular disease. Okay, go ahead.
Serum sickness.
Serum sickness. Okay, anyway, you covered some of the conditions. But very, very importantly, because we had a wonderful class on CBC, would you be interested in any other condition, less benign condition? 11-year-old child coming with polyarthritis without fever.
Viral arthralgia, sir. Viral.
Little more dangerous things. Role of peripheral smear, he was stressing. Peripheral smear, he was stressing. Red flags.
Less benign.
We have seen many acute leukemias presenting with polyarthritis. We have missed many. I think Balasubramanian sir will definitely would have had experience with this. many times we used to miss because the peripheral sphere report comes a little late, and we probably sometimes even start on aspirin. So this has happened. So always in suspected rheumatic fever, you always do a CBC with the peripheral smear. It's very, very important. Just
Okay,
like
sir.
we do a MAN2 before starting steroids. That is less important, but what is more important is doing a peripheral smear. Right.
Okay, sir.
Next.
Shall I proceed, sir?
Yeah, please. Quickly go through this. Yeah.
Antenatal history, second child, birth interval 2 years, booked and
Yeah,
immunized.
he's a 12-year-old child, no? I
Yes,
think
sir.
antenatal history, birth history may not be very important. The only
Okay,
thing is
sir.
birth weight is good, 3.5. Postnatal is okay, immunized, fine. Then antenatal history is fine. Yeah, I think immunization. Next slide.
Developmental history, age appropriate milestones achieved, studying same standard, good scholastic performance.
Very good. Super. Okay.
Family history is a
Family history.
non-consanguineous marriage. No history of
No history
similar
of illness. Right.
similar
No heart
family,
disease.
no history of any heart disease in other family members.
Okay. So see, suppose this patient we were persuaded to believe that this child has a heart disease, possible valvular heart disease. So, do you have any heart disease which can run in the family? Rheumatic fever is unlikely, but any other heart. Why are you asking for the history of any heart disease in other family members? Is it because of rheumatic fever or something else?
Congenital heart disease can
Yeah,
have.
no, what about acquired condition? Here we are basically thinking of a potential acquired condition. Acquired heart disease which can run in families, which can sometimes affect the valves also. Anybody?
Mitral prolapse.
MVP can run in families. Yeah, rarely. Then
Bicuspid.
any muscle disease, primary myocardial disease which can run in family. Hypertrophic cardiomyopathy is one, which has an autosomal dominant pattern. Even dilated cardiomyopathy, now increasingly people believe that 30 to 40% of DCM has a familial or a genetic basis. So we should think of these conditions. There are many other muscle disorders which can run in the family. So whenever you ask for a history of any heart disease in the other family members, you should not only think about congenital heart disease, but also of acquired heart disease. Then you can have some acquired heart problem without structural problem, like arrhythmia, like Brugada or a WPW syndrome or a long QT syndrome. So many things can run in the family. Okay, right.
Yes.
Next.
Okay.
Why did you ask for similar illnesses in the family members, doctor? And what illness were you asking for specifically?
Sore throat fever history, sir, in family members.
Yeah, I think you'll have to elaborate on that, because till now you have not laid any setting for rheumatic at all to me. Okay, there is nothing to suggest there was a preceding streptococcal infection anywhere. It need not be there. Not saying it should be there, but you have not given anything to suggest that this is a streptococcal associated illness. So you have to elaborate. You cannot just say similar illness and leave it at that.
Okay, sir.
Can rheumatic fever run in the family?
Yes, sir.
Genetic predisposition is this.
Is it less likely, very likely?
Less likely.
Less likely. Okay, good. Still possible. Okay, because they may share the same environment and all. Because there was a time when we were postgraduates in the 80s, ancient times, 45 years back, 40 years back, there was a textbook description that rheumatic fever was probably inherited as an autosomal recessive trait, but that is no longer valid now. Right. Okay.
In diet history, on 24 hours recall method, the calorie intake was expected to be 1,750 kilocalories, child was taking 1,600 kilocalories, with a deficit of 1,150 kilocalories. A child is taking a protein of 28 grams and expected is 35 grams, with a deficit of 7 grams. Contact history, no history of contact with open case of tuberculosis.
You are making Maniram again uncomfortable. Okay. Socioeconomic status. Okay. Quickly.
Just out of curiosity, this contact history, does it still hold? Is there still a need to specify this in 2025? But I leave it. That is not.
Maniram, the problem is there was a study somewhere in the 2020s looking at why do people die? Why do people die? What are the causes of death in India? So they said only 5% died because of infection. We thought it was much higher. Only 5%. But among the 5%, the two most common causes of death were in India, overall in India, was tuberculosis and malaria. So naturally, she has some justification to ask for an open contact. Anyway, okay. 2 rooms, 4 members. Overcrowding is present. Okay. 5th standard.
Socioeconomic status, Akka house.
What about the mother?
Mother didn't study,
Education status of the mother?
Mother didn't study, sir.
She didn't study at all, or you didn't ask?
Primary school only.
You didn't ask. Honest, be honest. Intellectual honesty. You didn't ask. Yes or no? Be truthful. But
Ask, sir.
I cannot imagine in Tamil Nadu and Kerala a lady has not gone to school. No, it's very difficult for me, especially from. Anyway, it doesn't matter, but it matters. It matters very much. It matters very much because the father studied only up to the 5th standard, and the mother, according to you, has not entered a school, which is a very, very, very unpleasant thing to learn. So, because there is very important education status of a mother is directly proportional to the well-being of the child rather than the father's education status, right? Okay, go ahead. Maniram is tempted to ask about the Kuppuswamy classification. Are you?
No, sir, but it's interesting
But
that
you should know
a postgraduate, but still open defecation is there, which is slightly,
that open defecation is still present. They are from Theni, eh?
Yeah, they are from urban area, but still, and living in a Pakka house also.
Pakka house, that is very interesting. Yeah. One kitchen, one common. Right. Okay, go ahead. And you should know in the examination, when was Kuppuswamy classification last modified? The year they will ask you. Just for a whim, the examiner will ask you and you will be in trouble. So be very careful with the Kuppuswamy scale. Right.
Then. And per capita income is 13,000. That means they're earning, my father is earning 52,000 per month.
13,000 per month.
Per month.
Per month.
Yes.
Per month means he's getting
around 500 days.
500 to 600.
Yes, sir.
Yeah, that is okay. Daily wage labor in Tamil Nadu. Right.
In
Kerala, it may be different.
Per capita means there are 4 members, right? That is how you calculate per capita still. Per person is
that's the point. Yeah.
Yes, I think you made a mistake in that. So.
Yes, sir. We'll correct it, sir.
But you can say is that total family income is 13,000 per month.
Okay, sir.
Okay.
Who is the 4th member?
Mother, father, 2 children.
Elder
child is there. Okay.
Yes, sir. Elder sisters.
Okay, right.
11-year-old male child, second born out of non-consanguineous marriage, presented with acute onset of fever with migratory joint pain involving large joints with no deformity, with normal perinatal history, with normal nutrition and immunization status, with no family history of heart disease, belonging to lower middle social economic class with overcrowding, of acute rheumatic fever.
The problem is
history is not suggestive of rheumatic fever from whatever you have said.
Another practical problem is that you are presenting this case and see whenever you have acute rheumatic fever, why are we worried? Is it because of the joint or we are worried about something else? We are worried about the cardiac involvement. So you should specifically say that onset of migratory joint pain involving larger joint with no deformity with no history suggestive of any cardiac decompensation, implying that there was either no carditis or there was only very mild carditis. That is very important in the summary. That's very, very important because you are, as Maniram was pointing out, you was fixated on acute rheumatic fever. Here again, you had said presented with acute onset of fever with migratory joint. It is not so. Actually, acute onset of fever was 1 week prior to the onset of this thing. But at that point, you could have probably mentioned whether there was a throat pain or whatever it is. Then one more question I want to ask about this throat, what do you call as a receding throat infection. Is suppose you have 100 rheumatic fever in our state, how many will have history of sore throats? Approximately. All of them? 50%. Okay, right, good. Okay, so you have only one diagnosis, acute rheumatic fever. Suppose I say this is Lyme disease. Is it possible to have Lyme disease with the presentation like this?
Monoarthritis, it will be usually.
No. There can be polyarthritis.
Okay.
What else will be there? What will be the other manifestation of Lyme arthritis?
Pain
What
will be.
is the skin? What is the skin change? What is the skin abnormality which the examiners are very fond of asking? Anybody knows something about erythema chronicum migrans and all? Heard about it?
Yes,
No.
sir.
Erythema chronicum migrans, they will ask you. Another thing is very important to remember, very important, because this happens with the MD pediatrics examination. What happens is that they will ask you differential diagnosis of polyarthritis with cardiac involvement. Naturally, we will include a Lyme arthritis. The catch is, in Lyme arthritis, there is cardiac involvement, but no valvular involvement. It affects the conduction system. There is no genuine MR or AR in Lyme arthritis. So that is a very important catch point in the examination. Okay, go ahead.
Why can't it be even simple post streptococcal even or post infective reactive arthritis?
Reactive arthropathy. She mentioned that.
From your history, that is a more likely diagnosis than rheumatic fever, correct? At least at the history, we have not examined the child, we have not done any investigations. Yes. But based on your history, my first diagnosis will be a reactive arthritis rather than acute rheumatic fever, because there is nothing for me to suggest that there is, how do you diagnose rheumatic heart disease? Clinically?
Carditis.
Sorry?
Carditis.
No, so use the Jones criteria, right?
Yes, sir.
So Jones criteria, you should have two major, one major and two minor, right?
Yes, sir.
So far, you have given only one major criteria. Okay, you've not given, there is nothing else in the history to suggest rheumatic fever at all. Right?
Yes, sir.
So I think I would probably put, a reactive arthritis first. And then, of course, I'm not saying it cannot be rheumatic fever, but having that as the only differential diagnosis with absolutely nothing to support in your history. You have only one major criteria. Okay. Yes. I find it very difficult to say that's the only diagnosis you have at the end of the history. Okay.
Okay, go ahead. The physical findings.
Bala sir, do you have any comments and
questions? Dr. Brinda, nice history you gave. I have a few comments. Of course, Dr. Sulfikar has already said, the cutoff marks for our pass in the exams is 50%. Many things in rheumatic fever are 50%. He already said only 50% of those who have rheumatic fever give a history of sore throat. On a similar note, only 50% of those who have established rheumatic valvular disease give a history of rheumatic fever. So remember, 50% is very important for rheumatic fever. That's one. Second, in the history, if you're thinking of rheumatic fever, you have to add one more history today in 2026. A new finding has been observed, not reported from India, but from New Zealand. They have identified cases of pyoderma resulting in rheumatic fever. So I think Dr. Brinda, PG students will be aware that even pyoderma can lead to rheumatic fever. So in this child, I would have elicited history of pyoderma. This is a new development. In fact, I'm sure Dr. Zulfikar would agree. During our postgraduate days, we were taught that pyoderma does not cause carditis, does not cause rheumatic fever. That teaching is gone. It can come.
Okay.
Third point, rheumatic fever may not run in families, but they are increasingly, in the next 10 years, I'm sure, they will identify the gene locus for predisposition to rheumatic fever. So it can come in the same family in more than one person. And I'm sure there should be some the molecular mimicry must be because of a genetic focus. And I'm sure our exome sequencing will identify predisposition to rheumatic fever in the near future. That's a futuristic prediction I'm making. Fourth point, Dr. Maniram raised the possibility of post-streptococcal reactive arthritis. In fact, we in India, we tend to underdiagnose this entity. But if you ask me how many cases I have diagnosed only one case. I'll tell you what happened. Post-streptococcal reactive arthritis, in contrast to rheumatic fever, has some differences. One, it tends to occur in children who are younger than those with rheumatic fever. Point number one. Two, it does not have a typical migratory arthritis. I think your migratory joint pain is not a feature of post-streptococcal reactive arthritis. Is actually, the arthritis will persist for about 4 weeks in the same joints. And it might involve even the small joints, in contrast to rheumatic fever. And post-streptococcal reactive arthritis originally was never thought to cause cardiac involvement. Now they say it can result. In fact, some authorities, Dr. Zulfikar will know better, recommend even 1 year prophylaxis following post-streptococcal reactive arthritis. And last but not the least, this sort of pattern of 1 man without fever again in post-streptococcal reactive arthritis doesn't occur. And in this child, two diagnoses I would have considered. In addition to saying that there is a possibility of this being rheumatic fever, I would have said this could be a reactive arthritis. And in fact, an intelligent student, if he gives a history of contact with tuberculosis, he can still defend. Because tuberculosis, in India, tuberculosis and syphilis can cause anything. Tuberculosis can cause a type of reactive arthritis which is called Ponset's disease, PONCET', which is a type of reactive arthritis which occurs in disseminated or multiple areas of tuberculosis. That is well described. Even that can occur in tuberculosis, you can defend. And again, defending history of bronchial asthma, again, you can do that, saying, if this is rheumatic fever, if I ever to start aspirin, I'll be careful. So, intelligent PG, when he gives a history and the examiner questions you must know the ways of escaping the rope of difficult examiners like Zulfikar. These are my comments. Thank you.
Zulfikar, more like Maniram.
Thank you so much, sir.
Anyway, the point is very important. I think this the dermatology issue, that skin infection can be a co-factor. I think it's very important. People can ask you about that in the examination. Okay. General examination.
Patient is conscious, oriented, comfortable sitting on the bed in room yard, pale present, no cyanosis, no clubbing, no excess, no pedal edema, no lymphadenopathy, and JVP not elevated. Vital, a temperature 90.4 degree Fahrenheit, heart rate 120 per minute, tachycardia for that age, pulse regular in rhythm, normal in volume, no special character, no radio-radial delay, and no radiofemoral delay, felt equally in all accessible peripheral vessels. A respiratory rate 20 per minute and thoraco-abdominal type of respiration. Saturation of 99% in room yard. It's like that 2 seconds. And BP in right upper limb. It was 100 per 60 millimeter of mercury in sitting position. And left upper limb 100 per 50 millimeter of mercury.
I just want to intrude into this. because it takes a lot of time to take blood pressure. 4-limb BP in this particular patient is not very important.
Okay,
See, if
sir.
you are looking at the congenital heart disease, suspected congenital heart disease, which might where you definitely take one upper limb and one lower limb. Even in so-called suspected rheumatic, when you get an AR, you have a Hill sign, etc., etc. It is enough that you take a one upper limb BP and one lower limb BP. And that lower limb BP itself, there is no need to take actually waste time by taking systolic and diastolic by Oscar. It will be very difficult to put them on a prone position and take the BP by sphygmomanometer. So what you do is you take a systolic BP in the lower limb. So take a regular upper limb BP like 100 by 60 millimeter in sitting position or whatever. You take one lower limb BP systolic, you say 110. That's all. Because all the changes, abnormalities in the blood pressure between the upper limb and the lower limb involve almost always systolic BP. So once you comment on the systolic BP on the upper limb and one lower limb, that is enough for a ordinary situation. But in the newborn, things are much different. But in this child, I think you can save time because this is a what you call as a well-prepared case presentation for a case presentation series. You will have enough time to that. But the examination, that much of time is not there. And you have one finding, tachycardia without fever, no? 98.4 Fahrenheit and 120 per minute is definitely slightly abnormal on the. So tachycardia is possibly, yes. Pulse otherwise is normal. Blood pressure is normal.
Yes.
Is there any widening of pulse pressure? Not much, no? 50.
Yes.
50. Little suspicious because one left upper limb showed 100 by
50.
50 is in the upper limit of normal in a 11-year-old child, right? Okay. So suppose there is a slight widening. What will you think of in this patient?
Aortic
In this
regurgitation.
patient? Yeah, possible aortic. Possible. Okay, right. Go ahead.
So sir specifically pointed out, no, temperature is normal, but there's tachycardia. Why did he point it out exactly? What should you think of when you see that?
In myocardial involvement, there can be disproportionate tachycardias.
Okay. And you had no history suggesting some myocardial involvement, right?
Yes.
But can it still happen?
It's a palpitation complaint the child might have.
Like in rheumatic fever,
Yes.
can you have no symptoms to suggest have cardiac involvement? Is it possible? Because you said there's no breathlessness, you said there's no orthopnea, there's nothing, and even the activity levels are normal, no fatigability. Yeah, is that possible?
Vital regurgitation can be.
There's actually a terminology for that. It's called latent carditis. There might not be very obvious symptoms or signs of myocardial involvement, but there can be very subtle things. Just tachycardia alone and echocardiographic features alone might be present. Okay.
Yes, sir.
Head to foot examination. All cavity.
Anything in particular? Because it's already 9:45. So anything particular? Otherwise, we will go to the cardiovascular if there are abnormalities.
Okay. Yes, sir.
Wrist joint, no swelling, no redness. When do you say arthritis actually? When do you say arthritis?
Your swelling, redness, tenderness, and the warmth will be present in arthritis.
You need everything to say arthritis, like swelling, redness, tenderness, restriction of activity. All 4 of them you need, or 2 or 3 are enough? What do you feel? No, if everything is there, there is no doubt. But usually, two out of 3, like swelling, redness, tenderness, restriction of movement. I think 3 out of 4 probably would be enough to say it's arthritis rather than arthralgia. Okay, right.
Anthropometric.
Okay.
Normal. So
Growth is normal. Right.
Normal.
Go ahead. Yeah.
Systemic examination, cardiovascular system, inspection, chest wall symmetrical, trachea appears to be midline, apical impulse noted in left fourth and fifth intercostal space at mid-clavicular line, no precordial bulge, no other visible palpations, no stars, no hyphosis and scoliosis.
You have been, you yourself have led into a trap because this is an inspection. And you are saying apical impulse is noted in the left, fourth, and fifth intercostal space. You are very specific, This is only inspection. So that is the reason why we always advise you to combine inspection and palpation together. So avoid overlap and such minor mistakes, which can sometimes cost you in the examination. So I think we will skip this and go to the palpation, see what is happening.
Yes. Palpation, axial position confirmed to be midline, apical impulse felt in left, fourth, and fifth intercostal space at mid-clavicular line, hyperdynamic in nature, no thrill, no palpable or sound present, no parasternal heave, it's normally felt, no thrill.
Okay, so you are saying that the apex impulse is felt both on the fourth space as well as on the fifth space. Right. So do you want to say it's a diffuse apex or what?
Hyperdynamic.
No, hyperdynamic is different. That is a different thing. That is a nature, location. See, what is apex? Apical impulse, 3 points you have to see. One, location. Second, nature. Third is presence or absence of a thread. So you have mentioned two. One is the location, another is the nature. Thrill you have not mentioned. Anyway, may not be, there is no thrill. But this fourth and fifth business is little tricky. You have to commit on either fourth or fifth. So what is called as apical impulse? Apical impulse is the lowermost, most and outermost palpable cardiac impulse. If it is like that, which will be more suitable to you? Fourth or fifth?
Fifth intercostal space.
So you commit on that. See, apical impulse is felt on the fifth intercostal space in the mid-clavicular line and hyperdynamic in nature. Okay. From this that sentence, is there cardiomegaly or not? 11-year-old child, fifth left intercostal space in the mid-clavicular line. Is it cardiomegaly or not?
Yes, sir, cardiomegaly.
Why do you say that so?
Actually, at this age group, the apical impulse should be medial to the mid-clavicular.
It should be medial. So there is a borderline cardiac involvement and hyperdynamic in nature. Okay. Hyperdynamic in nature.
What is hyperdynamic? What is hyperdynamic apical impulse?
The apical impulse felt in more than one intercostal space, which was ill-sustained. Forceful.
What does it imply generally? What does it imply?
Volume overload.
So if the apical impulse is hyperdynamic, that means there is significant volume overload.
Yes. Okay.
So I am very surprised that the apical impulse is only in the fifth space mid-clavicular line, and then you have it doesn't correlate at all. If you have a hyperdynamic apical impulse, it means there is significant volume overload. I would have expected a much significant apical impulse shift compared to what.
Vrunda, can you defend by saying that this patient is anemic because you are committed on pallor?
Yes.
Not completely, but partially you can say that maybe there is significant anemia. That may be the reason. For maybe there may be a mild regurgitation with anemia that probably could cause this hyperdynamic. But this is a dangerous thing. Left to fourth and fifth thing. It's very, very dangerous. Okay. And no RVH, no parasternal heave, no palpable heart sound, no thrill. Carotids are normally felt, no thrill. Okay, fine. So, so the only two findings are, one is tachycardia, resting tachycardia. Second is borderline cardiomegaly with a hyperdynamic nature, which as Maniram was commenting, which does not go very well. That minimal cardiomegaly with a hyperdynamic apex. Right, go ahead.
Percussion, left heart border corresponds to apex.
Stop you here, and you'll have to tell me truthfully, did you do percussion of the cardiovascular system?
No, sir.
I have never done a single percussion of cardiovascular system in my entire career. And I've been a cardiologist for 12 years. Okay. Even when I did MBBS, percussion was of the cardiovascular system was not present in Hutchinson's. Okay. When I did MBBS, that is nearly more than 20 years back. Okay. These are all traps which you are falling into. Nobody does percussion of the heart. Nobody expects you to do percussion of the heart also. Okay. If you put it immediately, I know you've not done it. And you just made it up. Okay?
The point is, you must overall, because sometimes I almost completely agree with Maniram, but still the point is that in pediatric examination, the problem is sometimes in older children, they sometimes expect you to percuss out the heart border, the liver, etc., because of the cardiac malposition, etc., pericardial effusion, blah, blah, etc. So, but most important thing is avoid percussion below 2 years, because it is basically very uncomfortable to the baby as well as the parents, right? But then once you commit on percussion findings, they will ask you, what are the uses of percussion in cardiology? Can you tell me 2 or 3 situations where percussion could be useful?
In situs inversus.
Situs inversus, it's palpable. Basically, not situs. Yeah, liver can be palpable on the left side or whatever. Then dextrocardia, no, the heart border can. What else? Pericardial effusion, something.
Yes.
So there are situations which is useful, but be very honest. That is the most important point. Okay. Now the auscultation, I will start commenting on this. Why? Because ഇതും മണിറാം പറയുന്നത് പോലെ ഇത് ഓൾഡ് ഫാഷൻഡ് അപ്രോച്ച് ആണത്. അതായത് when you auscultate, you comment on heart sounds first. Comment on S1, S2, presence of S3, S4, any abnormalities in the systolic sound, any abnormal sound in the diastole, then go to murmur. When we were doing MBBS, as Maniram was pointing out, we used to start with mitral area, then tricuspid area, aortic area, etc. Then what will happen is there is a duplication. So what you do is you comment on the first heart sound. So what is your comment on the first heart sound? First heart sound is soft. Where do you hear the first heart sound? From the apex. With what part of the stethoscope? Diaphragm or bell?
Diaphragm.
Because first heart sound is a relatively high pitched sound. So you auscultate at the apex with the diaphragm, and you find that the first heart sound is soft. Okay. Now you go to the second heart sound. Where do you look for second heart sound? Where do you auscultate for second heart sound?
The pulmonary area.
Pulmonary area as well as aortic area. The base. Aortic area also, but mainly on the pulmonary area. Now, when you say second heart sound is normal, what do I understand?
With normal split intensity and normal intensity.
Abhinaya can say.
Sir, with normal intensity and with normal split, sir.
What is meant by normal split?
A2 followed by P2. A2 is slightly louder than P2. Sir.
What else? What is the relationship between second heart sound and respiratory cycle?
During inspiration, the splitting will be heard prominently, sir. During expiration, single sound will be heard, sir.
So is it a high pitch sound or a low pitch sound?
High pitch.
Second heart sound is a low pitched or high pitched? Be confident.
High pitch.
High pitch. It is the most raised pitched sound in the heart. And so the normal second heart sound means it is split during inspiration, single during expiration, and the P2 is softer than A2. That is when you say the second heart sound is normal. So when a PG says that second heart sound is normal, I expect that the postgraduate has clearly distinguished these 3 things. Then after that, you go to the third heart sound or a fourth heart sound. So in a suspected rheumatic fever, with the cardiac involvement, do you expect an S3 or S4?
S3.
You will expect an S3 because of the volume overload situation which can occur. Okay. So, but no S4. S4 is practically unknown in acute rheumatic fever, and even in chronic rheumatic heart disease, S4 is very, very unusual. So first you should say first heart sound is soft, second heart sound is normal, third heart sound is not present, right? Then there is no added sound in systole or diastole or whatever, if it is there. Suppose there is an added sound in diastole in this patient, what will be the implication?
It might be due to associated mitral stenosis, functional mitral stenosis.
Which is causing
Opening
no, if an opening snap, it may be due to organic mitral stenosis, which would have been present previously, because in mitral stenosis, what happens is that only 1/3 of mitral stenosis gives a history of rheumatic fever in the past, very low percentage. So then you go to the murmur in systole, you go to the murmur in the diastole. Now, I want to ask one more question, and before unleashing Maniram on your pansystolic murmur, why is this first heart sound soft? What do you think is what are the reasons possible? Brinda?
When mitral excitation can be soft.
Yes. So one factor is that the most common manifestation is mitral regurgitation, where there will be lack of coaptation of the leaflets. So you will have a soft S1. Right. Any other reason? That is the usual question asked in the examination. If you give that answer, the examiner will be very happy. See, what is the ECG abnormality which is found commonly in rheumatic fever, rheumatic carditis with
prolonged PR interval, sir.
Prolonged PR interval. Well, how does prolonged PR interval affect S1? It becomes soft. So short PR interval makes the S1 louder, and a long PR interval makes the S1 softer. That is the second reason in the examination, right? That's the second reason. Third reason, there can be rarely in a small percentage pericardial effusion, transient pericardial effusion, because we have been taught that carditis in rheumatic fever is a pancarditis. So sometimes mild pericardial effusion, which is very rare, honestly. Mild pericardial effusion can again make the first sound soft. So theoretically, there may be three reasons, but the most important single reason is the presence of a significant mitral regurgitation, followed by a prolonged PR interval if it is there, and third, less likely possibility of a pericardial effusion. Okay. Now, Mani.
So
go ahead, Mani.
Whole page, what is very striking and very scary is the description of the murmur. Okay. So, Doctor, we'll go into systolic murmur. What are the things which you will describe for a systolic murmur? Just list out.
Location. So grading.
First, you have to say systolic, diastolic, continuous. So this is systolic.
Yes, sir.
And then after that?
Intensity.
Early systolic murmur or pansystolic murmur?
Or mid-systolic murmur.
Yes.
Or late systolic murmur.
Early systolic murmur.
Ejection systolic.
No.
There is an early systolic murmur also. So what is it? So generally, early systolic murmur is something which you hear in small muscular ventricular leads. Okay. So if you have a small muscular VSD, the shunt happens only in the first part of systole.
Okay.
After that, there's not much of a shunt. So an early systolic murmur in a small child at least is almost very specific for a small muscular VSD. You can make a clinical diagnosis including the location based only on the murmur alone. Okay. But generally in an older child, you don't see that because most small muscular VSDs would have closed off. So you only have an ejection systolic murmur and pansystolic murmur. Of course, you can have a mid-systolic murmur with mitral prolapse, but it's only ejection and pan. Okay. Okay, then
Grading.
so what does grading signify?
According to Levin's classification,
No, what does it quantify? Grading should quantify something, right? Like what does it quantify?
Loudness, no? Grading.
Loudness
only, no?
Loudness.
It is not the pitch and loud, it is the loudness. What is 4/6 murmur?
Associated with thrill, sir.
Okay, oh, you're very fast. What about 5 and 6?
Partially away from the static is partially away from the chest with the thrill means it is a 5, sir.
What is that partially away? What is
sir,
the difference between partially away and completely away?
Grade 5, the rim of, even with the rim of the slit, the murmur
Yeah,
is hearing, sir.
the rim of the yeah, they are all outdated things, but basically you should know as a postgraduate, you should know all 6 grades of systolic murmurs, and also basically even the diastolic murmurs also can be graded into 6. But practically the original Levin's grading was meant only for
Systolic murmur.
systolic murmur. You should know that. It was very, very far away, 1933. That time only ECG and X-ray was there. So at that time, people wanted to decide whether that particular murmur was significant or not. That is the reason for this Levin grading. And now Levin's grading is primarily used to make you uncomfortable in the examination. So don't become uncomfortable. Be clear about the grading of the murmurs.
Yes.
So we got timing of the murmur and then the loudness of the murmur. Then what else next?
Nature of the murmur, no, character of the murmur. You have said blowing murmur, right? Blowing. Then pitch also you had commented. What is that? High pitch, right? So high pitch paranju, nature paranju. What is this?
Sir, question.
What does a pitch signify? Like high pitch, what does it tell you? Because that's the first thing you have written, high pitch. So what does that tell you?
Pressure grading.
Sorry? So what causes a murmur? What causes any murmur?
Turbulence of the blood flow through
the so the blood flows from a high pressure place to a low pressure place. Okay, it might be a chamber or vessel, but it flows from a high pressure place to a low pressure place. The pitch actually tells you the degree of pressure difference between the two chambers. Okay, so high pitch means there is very high pressure difference. Okay, so you cannot have a high pitch in a tricuspid valve murmur. So if you have severe tricuspid regression, unless there is severe pulmonary hypertension, you will not have a high pitched murmur. So it tells you the pressure difference between the two chambers involved, or the chamber and vessel, whichever. So high pitch here tells you that there is a very significant difference between the two chambers. So it is more likely to be again MR because you hear it best in the apex. Okay. So and then what else should you? Radiation. So I find it very interesting. It's high pitched, soft blowing, pansystolic murmur, grade 3/6, which is radiating to the axilla and back. So if it's radiating to the axilla and back, that means that the left atrium is very significantly enlarged, right? So I'm very surprised that your patient is completely asymptomatic from a cardiac perspective and has a very soft blowing murmur, maybe because the left atrium is very enlarged, so the murmur gets a bit dampened out. But with such significant left heart enlargement based on your murmur findings, I am very surprised that your patient is completely asymptomatic from a cardiac perspective. Okay, I'll have to be brutally honest. I think this entire auscultation has been cut pasted from a textbook, not from your patient. That is the impression which I get based on the auscultatory findings. Okay. Because you have a soft first heart sound, that means the mitral valve is not coopting well. Second heart sound you mentioned as normal. I'm completely happy with that. But high pitched at the same time a soft murmur, grade 3/6. So all of this tells me, mitral regurgitation is at least moderate. And then radiating to the axilla and back, which means left atrium is significantly enlarged. So that means that, it's probably severe. And your patient has absolutely no symptoms to suggest cardiac involvement. So to me, and again, the heart size is only at the fifth intercostal space. So none of your findings correlate with either between themselves and with your history also. Okay.
Brinda, you are there. You are there. Not
Yes.
completely demolished. No, you are
Yes.
there.
Yes.
Yeah. You are still there. No, the point is, you can again to Maniram, you can argue that regurgitant lesions, MR or AR, are usually asymptomatic, even if they are moderate or severe. Majority of these regurgitant valvular lesions can be more or less asymptomatic, almost functional class 1. So that is one answer you can give to him. That is one reason. Another reason is that, because we have seen moderate, this is probably a moderate MR, which probably is not very much symptomatic. So that is the only way of defending that. And another thing is that if it is a moderate MR, 3/6 murmur, pansystolic murmur, you would have expected an S3. Generally, an S3 would have been expected. What else would you expect in this patient? Suppose, as Maniram was saying, this is conducted to the axilla and the back, so at least it's a moderate to severe MR. What murmur would you expect? Where? You are dealing with a moderate to severe MR in this patient.
Yes, sir.
And you expected an S3, which is not there. What other murmur would you expect in a moderate to large, moderate to severe mitral regurgitation?
Carrying murmur.
Carry-goose.
No.
Oh God, not carry-goose.
So all the blood, from the goes from the LV to the LA, right?
Yes, sir.
Then what happens to the blood after that? From the LA, what happens?
Comes
Across the
mitral valve, sir.
mitral valve. So it will
Yes.
produce a.
So is there more blood going through the mitral valve or normal amount of blood?
More amount of blood, sir. So
what does
So
it
there can be a.
diastolic murmur.
There can be a diastolic.
What diastolic murmur? What diastolic murmur will be heard?
Mid-diastolic murmur.
Mid-diastolic.
Essentially, it's because of mitral stenosis.
Yes.
Functional mitral stenosis.
Functional mitral stenosis. What will be missing if there's a functional mitral stenosis? What auscultatory finding will not be there?
Opening snap will not be there, sir.
Correct. Opening snap will be there. Opening snap. Opening snap, is it a high pitch sound or a low pitch sound?
Low pitch.
Okay, something between, doesn't matter. What about S3 and S4? Low pitch, high pitch? Quickly, somebody, 3 of you.
Now we discussed what pitches, right? So
low pitch.
Low pitched. So S1, S2 are high pitched,
Yes.
S3, S4 are low pitched,
Low pitch.
and the opening snap is somewhere in between. It is comparatively sharper than a normal S3 or an abnormal S3. Next slide. Any surprises for us? The next slide, because it's already 10, 10. Same pansystolic murmur. I mean, Brinda,
Sir, we can take
sorry,
a time,
I'm
sir.
switching.
Also,
Sir, you can take
Hello?
your time, sir. We can have 20 more minutes of discussion, sir.
My God. Okay. Now, Brinda, because this is a learning session. So one thing is that this kind of presentation of auscultation is not acceptable now. Now what you have to say is that S1. So if I were a PG, I would say S1 is heard soft. S2 is well split during normally heard with a normal intensity of P2. No S3, no S4. No added sounds. No pericardial rub also you can say, because rarely you can have pericarditis in rheumatic fever, very rarely only. Then you should say, as you go back to the previous slide, you should say there is a grade 3/6 pansystolic murmur, high-pitched blowing murmur heard anyway better with the diaphragm of the stethoscope and radiating to the axilla. And another additional thing you should say as a postgraduate is that whether it increases with the hand grip. You ask them to have a hand grip, firm hand grip, and usually it increases on hand grip and also it increases on expiration. So this is usually to be mentioned in the postgraduate examination, not at the MBBS level, but at the PG level. Then you should say no S3 gallop. And next slide, go to the next slide and convey to the examiner that you have looked for a MDM, that you have not convinced him. You have not convinced Maniram that you have looked for a mid-diastolic flow murmur. That's very, very important. Don't say S1, S2 heard with normal. You don't auscultate pulmonary area for S1. You auscultate pulmonary area for only S2. No other murmur heard, right? So you should say heart sounds first, additional sounds first, second, and then finally murmur in systole, murmur in diastole. If sometimes in a PDA, you should say it in a continuous murmur, right?
Yes.
Okay.
Actually,
Now,
you can do away with this area-wise auscultation. Actually,
yeah, that is the
doesn't
point.
make any sense at all. Okay, what we want to know is, as sir mentioned, how is the first heart sound, how is the second heart sound. More importantly, again, how is the split and all of that. So you can do away with these areas. I think most people will not expect you to do this.
Okay, sir.
What else is there? So what is your final diagnosis now?
11-year-old male child, second born out of non-consanguineous marriage, presented with acute onset of fever with migratory joint pain.
Doesn't matter. You go to your working diagnosis.
It is acute rheumatic fever with carditis involving mitral valve, probably mitral regurgitation in sinus setup with no evidence of pulmonary hypertension and complications of congestive cardiac failure and infected endocarditis.
Okay. Now the problem is if you make a diagnosis of acute rheumatic fever with cardiac involvement involving the mitral valve, absolutely, you may be right, absolutely. But you should never mention without complications of congestive failure and infective endocarditis, because infective endocarditis is not a complication of acute rheumatic fever. You should say without cardiac failure in sinus rhythm with no evidence of pulmonary hypertension. But you should definitely say MR probably Allah, it is MR because you are getting an apical pansystolic murmur at the apex conducting to the axilla. There is no other diagnosis. It is anatomically mitral regurgitation. Your job is to decide whether that MR is mild, moderate, or severe. What do you feel? What do you feel?
Moderate.
Between mild and moderate, what do you feel? Which will you choose? Mild MR, moderate MR? Choose. Moderate MR. Because moderate MR can be asymptomatic also. So you should say moderate MR with no, and it is good to say that there is no clinical evidence of aortic valve involvement. That is also very important because if you have both aortic valve involvement and mitral valve involvement, even without heart failure, you may decide on choosing steroid rather than aspirin. Whereas if you have only mild carditis, the only one valve involvement without heart failure, probably you will be comfortable with the aspirin. But many times we give steroids. You understand that point? So you should say that also, absence of aortic, clinical aortic valve involvement, clinical. Now, now between Dr. Manira is skeptical about your moderate to severe MR. So you should show the X-ray first. Let's see what happens. Only this much, right?
Yes, leave aside this discussion for a few minutes. Just one thing which is, for me at least, which was very, which didn't correlate at all is, you have only two possibilities here. It's either an acute rheumatic fever with carditis, or it is an acute rheumatic fever complicating a pre-existing rheumatic heart disease. Okay, if you say there is acute rheumatic fever with this amount of mitral regurgitation, that means carditis is definitely significant, and I expect the patient to be very, very symptomatic. Okay, and if you say this is a pre-existing rheumatic heart disease with an acute rheumatic fever complicating it, then again, when somebody has cardiac involvement and has rheumatic fever again, you expect the carditis to be very severe. It's very unusual for the carditis to be mild in a recurrence of rheumatic fever in somebody who has rheumatic heart disease. In both these conditions, I would expect significant, symptomatic involvement of the heart, which is not there at all. So that has been a red flag for me. This is not for your exam, but for managing this patient. I honestly suspect the diagnosis of rheumatic heart disease itself in this patient. I might be wrong, but based on whatever you have shown, I seriously doubt if it's really rheumatic heart disease, doctor. A lot of things to me do not correlate at all. And again, cardiomegaly is not very great. Yes, there is some cardiomegaly. It is not. It's not very great. So I think for the management of this patient, I think you should revisit the diagnosis completely. That's what I feel. Sir, what do you think, sir?
No, yeah, but basically, I think in our part of the country,
not for the discussion.
Yeah, for the discussion itself, basically, if you have a 11-year-old child in our country, southern part of India, with a genuine polyarthritis, with a definite apical murmur, according to her, 3/6, so it cannot be wrong. At least there is a well-heard murmur in the apex. We should first think of acute rheumatic fever. And as you said correctly, the second point is that there has been a mild MR already a pre-existing mild MR, and recently had a rheumatic reactivation. That is also possible. But symptom-wise, I somehow feel I probably disagree with you that, because we have seen a lot of moderate to severe MR. Even clearly, this patient has been treated probably. What will happen is that we have seen many the moderate to severe MR becoming very patients becoming very comfortable with their moderate MR because they
in
adapt.
the setting of an acute carditis, sir.
Acute carditis within one week. Within 1 week of our therapy, we have seen a very comfortable child who had sometimes come in PND like thing becomes very comfortable because the left atrium adapts to the moderate MR and minimal pulmonary venous hypertension, as you can see here in this X-ray. We have seen that kind of presentation. And secondly, in experience now, the number of rheumatic fever is coming down, but still, what I find is that this that fever thing, you have been commenting on that fever. Many times the parents miss the low-grade fever because they give the NSIDs and all. So there is no documented fever before they come to our hospital. Then Brinda, one more question from me. ECG, what do you look for? What are the things? The first thing you should look for, what is that?
Rate.
Before PR interval.
Rate.
Heart rate.
Rate.
Heart rate is important because you said there is a sinus tachycardia, right?
Yes.
So you should take the ECG rate. Rate is important. Then prolonged PR interval. So what is prolonged PR interval in a child? In an adult, the cutoff is 200 milliseconds. milliseconds. Whereas in adolescents up to 16 years,
180,
this usually take as 180. 180. Is the ECG there? No,
sir.
Okay, doesn't matter. What about the counts?
Yes, sir.
CBC and all? Yeah. Leukocytosis, anemia, CRP is positive. Yes, sir. It's only 32. Maniram, you may be right.
Yes, sir.
ASO is positive, 400 international units. Throat culture is no growth. ECG sinus rhythm, grade 2 MR, PR, normal LV function. So the way the echocardiography report is represented here in this slide means that the MR must be very mild.
Yes,
Because grade 2 MR. What is the significance of TR in this patient, Brinda? There is, there have been situations where in the olden days where rheumatic fever was rampant. And one of my postgraduates will come and say, sir, there is acute rheumatic fever with carditis with all the 4 valves involved. So I'll get stunned, basically it affects only the left-sided valve. Left-sided valve. They will say all 4 valves are affected. Why? Because the echo reports will say grade 3 MR, grade 2 TR, grade 1 PR, and grade 1 AR. So all 4 valves. But you must remember that practically all PR by echo is physiological. 50% of TR in echo is physiological. Only a genuine MR and genuine AR are important in the diagnosis of rheumatic carditis. So here you can only say based on the echocardiography, there may be evidence of a mild carditis. PR is unimportant in this particular patient, especially without a history of a chronic rheumatic heart disease. If it is a chronic rheumatic heart disease, naturally TR may be because of the associated pulmonary hypertension. Then another very practical thing is that I reluctantly joined with Maniram in suspecting your credentials because ESR is 32, right? So if it is in the acute setting, if ESR is 32, very unusual. Why? Because even with heart failure, here there is no heart failure. Even with heart failure, in acute rheumatic fever, ESR will be at least more than 60 millimeter per hour. So it is a suspicious value you are getting. So probably, it's difficult. I think.
Patient came after 1 week without any treatment for rheumatic fever. So none of your findings, your history, and the investigation to me is suggestive of acute rheumatic fever. In fact, I strongly suspect the diagnosis in this child.
Okay.
One whole week without treatment for rheumatic fever in a child who probably, based on your findings, has some pre-existing rheumatic heart disease. And the child has this kind of investigations, this kind of symptoms, and this X-ray. I'm not convinced of this.
I think it's already 10:25. Anyway, to take rest, Brinda, for 1 day, voice rest and all. And the other 2 people for supporting her. I think very good. And anyway, it's the most important thing lesson I take from this discussion is that, as Maniram was commenting, that there should be an additional thinking also, rather than fixating on rheumatic fever with carditis. We must question the tenacity of the diagnosis. Only when you start questioning, you will get a better answer. I think that's a very important lesson which we all must learn today. Okay, so don't lose heart and all. It is okay. So I'll tell you one thing, because before my DM cardiology, I used to be a very popular what you call as a skilled assistant for MD pediatrics, because I was considered very friendly for the postgraduates. But what I have done is, I have noticed is that this case, if it is coming in the examination, it is reasonably safe to present it as a rheumatic fever with mild cardiac involvement. That is okay. So don't feel bad about it. Okay.
I'll tell you one story, doctor. This is when just before my FNB cardiology exam. So I went for a clinical exam, course in Fortis. Sir knows Savitri Shivasam, madam. She is
yes.
She is probably the mother of pediatric cardiology in India, okay? And she is an absolute terror, okay? So
She was my examiner.
I did not have any case presentation on that day, but my boss KK, he was one of the examiners. He came and then he said, "How can you not give any case to my patient, my student? You have to give Maniram a case." So they found one case and gave it to me. I don't know any Hindi. That patient was from Pakka rural UP. Okay, he didn't know a word of any other language except Hindi, and there were nobody to help me because it was not in the list of cases. So I got some history and all of that somehow. And Savitri ma'am was not there throughout the day. Mine was the last case. At 5 p.m., they added one extra case. Exactly at 4:55, she walked into the hall. She was not there for the entire day. And she was not even an examiner for me. She was just sitting downstairs. I started the presentation. She just tore into me. That presentation lasted for 2.5 hours. And I could not answer even a single question she asked, because if I answer something, she'll go into something else. And then the entire, she completely tore into me. But that actually made me a better, much better prepared for my final exam. So that is how I look at it. So I want you to, I think what happened was you got fixated with the idea of rheumatic fever. And you wanted to put everything together to convince us that it was rheumatic fever. I think if you had objectively presented what you saw and what you heard, then it would have been much easier. Okay, so you tried to sell rheumatic fever from the very first slide, whereas you didn't have any convincing data to suggest it was rheumatic fever. So that is the only thing which I want you to take away. Okay, I don't want you to get fixated on diagnosis and then try to put everything to favor that diagnosis. That is when you will get into trouble. Okay.
Thank you, sir.
Okay,
Thank you, sir.
I think that is.
Bala, sir, your comments and questions, please, sir.
Yeah, Bala.
Bala.
Dr. Brinda, don't get defeated. What you did was right. In fact, I will come to your defense. See, you must remember, most of the children we see, whether it is the exam case or in your practice, they don't read Nelson's textbook and present the way books have written about rheumatic fever. This is a typical case. I can tell you, I can swear this is rheumatic fever.
Exactly.
Okay, all that absence of fever for 3 weeks and all. Child might have received dexamethasone injection, and that might have suppressed the fever, might have altered the course of illness. You never know. And you must also remember, majority of those who come to you in the exams with rheumatic MS, MR, AS, AR, etc., they will not give any history of fever or arthritis or sore throat. So don't get nervous. This case, unless proven otherwise, it is only rheumatic heart disease. In fact, I would even go further ahead that this child might even be having an established rheumatic mitral regurgitation, because the echo shows moderate MR, if I remember correct, and already tricuspid regurgitation is occurring. I don't think tricuspid regurgitation will occur in acute rheumatic fever unless there is very severe carditis or cardiac failure. So
that would have been, sir, just physiological TR which is being noticed. That's all.
yeah, so this is likely to be an established rheumatic valvular mitral regurgitation, which is going on for quite some time. And this girl might not, and in fact, if a case like this comes, I'll go back again to rescue myself with good history. I would ask her whether she is going to school. Is she going to school, ma?
Yes, sir.
No. She has not been. Has she been going to school in the last 1 month?
No, sir. No, sir.
No. I mean, I have elicited history of exercise intolerance with more questions. Climbing stairs, walking fast. I'm sure there might, I mean, she will definitely have grade 2 or grade 3 dyspnea if you go into inquiry. I don't think. Another thing is, heart rate of 120 is either due to carditis or due to cardiac failure. If you don't have any other explanation, if there is no fever, in fact, one of the subtle clues for rheumatic carditis is tachycardia out of proportion to fever, tachycardia persisting during sleep, tachycardia persisting in spite of aspirin. This is what my professor used to teach us in undergraduate days. I'm sure Zulfikar would have heard this.
Yes, yes.
Okay, okay, that is this tachycardia is very much in favor of an acute rheumatic carditis in this girl. And in fact, when it comes to treatment of this child, 11-year-old girl, I think if I'm sure it is not infective endocarditis, if I'm sure it's not some comorbid infection, I would definitely give her steroids, treat her as acute rheumatic carditis instead of arguing on what the diagnosis is. That's my comment. And finally, we must also remember things are changing. In the sense, when we were students, we were taught only polyarthritis should be taken. Arthralgia is a minor criteria. Now, we must remember in the 2015 criteria, they have changed. Monoarthritis come as one of the criteria in areas where there is lot of rheumatic fever. So I think just because it doesn't fit into a holistic diagnosis of rheumatic fever, for want of any other diagnosis in this child, it is rheumatic fever, even though there is no history of fever. The term rheumatic fever you can use boldly, and you can still say that this girl is likely to have acute carditis for the simple reason she has tachycardia and still has had some recent joint symptoms. Joint symptoms might disappear in 4 weeks, whereas carditis can go on even up to 3 months. So subtle manifestation may be there, everything need not be there. And even ESR, CRP, all that might have subsided because she might have received some steroids or NSAIDs. They don't rule out a reactivation of rheumatic fever, and this should be treated as rheumatic carditis unless proven otherwise. The other point that's happening, the other developments that are taking place in rheumatic fever, mind you, just like, ASO is becoming less important. They are giving, in fact, throat swab culture is not required. Even rapid antigen test is accepted as proof of streptococcal infection. That's one change which is there in the new guidelines, right? And in the West, they are now talking about, just like our gene expert for tuberculosis, they are talking about gene expert test, PCR test for diagnosis of streptococcal infection as an office practice test. I'm sure 10 years from now, with the help of AI, if there is a family or the child prone for rheumatic fever, we'll have criteria for AI diagnosis of rheumatic fever with history, with throat swab, throat pictures, and also use of gene expert in the outpatient practice, where the gene expert means not for TB, it's for streptococcus. They will identify a PCR test which can be done in our office, and we can give penicillin or amoxicillin. And in this patient, I think we should give the benefit of treatment of steroids and also penicillin prophylaxis for this girl. These are my comments. Wonderful presentation, Brinda. It's not easy. I know Maniram's knowledge is as big as ocean, and Zulfikar's experience is 5 decades old. It's not easy to bat when they are bowling bounces at you. You did extremely well. Well done. Keep it up. All the best.
Thank you so much for all the valuable points, sir.
Thank you.
Last
Brinda,
question
can you
I
stop
want to ask.
sharing?
Abhinaya,
Yes.
Brinda,
can you
stop
hear me?
sharing, ma.
Abhinaya,
Okay, ma'am. Yes, sir.
Abhinaya,
Yes, sir.
last question before we say good night.
Yes, sir.
Is Tamil Nadu and Kerala, are they low prevalence area or a high prevalence area? According to the
Low prevalence area,
low
sir.
prevalence area.
Yes,
That's
sir.
very. So basically, the South India data from Karnataka, Tamil Nadu, and Kerala show the last 10 years we are all in the low prevalence, low incidence area. So the criteria, 2015 criteria for diagnosing rheumatic fever in our states, the Dravidian states, should be the regular ones. Not you should not dilute with the monoarthritis, etc. Polyarthritis continues to be the major criteria. Okay, I think Prasanna, I think we'll call it a night. Huh?
Yeah.
Yes, sir. Yes, sir.
Maybe
After
tonight.
such a wonderful discussion, so many people in participants are still listening, and both in Zoom and in YouTube also, sir. Somsundaram, sir.
Yeah. So
Somsundaram?
it was it's 10:30, and still the deliberations which were happening with all the three examiners who are all well versed with their wisdom, knowledge, and expertise. So it will be useful not only for today, sir. All these recordings are there in the YouTube, and you can see all those recordings have gone for about 2,000, 3,000 views within a week or within 10 days itself. So definitely all these discussions will be useful for the PGs who go through the website and the YouTube channel, sir. Thank you, Dr. Sulfikar Agabad and Dr. Maniram, for sparing your time, and Dr. SPS, sir, with always with us, taking the lead and then going through all the discussions. Over to Dr. Prasanna and Dr. Narmada. Thank you very much.
Sir,
Thank you as the postgraduates. All the three duo have withstood the bombarding of questions from all the three examiners. So hats off to you and all the best to your future. Thank you.
Sir, can we have a few words from Malar ma'am, sir? Vasanta Malar ma'am, can we have some?
1 minute. Brinda will get distinction with this sort of answering. Brinda, don't get worried. You did very well with Maniram and Dr. Zulfikar. Yeah.
Vasanta Malar ma'am, are you here? Can we have some few words from you, the mentor of Brinda, Binaya, and Kirti?
From Deni Medical College. First of all, I extended my thankfulness for the esteemed IAP members for this wonderful opportunity for our students. And thank you to Dr. Zulfikar sir and Dr. Maniram sir and Dr. SP sir for your wonderful insights. And as per Maniram sir, we also discussed that two valid points regarding that fever, absence of fever, and that absence of exertional dyspnea. And then we concluded to present the same slide to the forum, sir.
That's fine. I mean,
thank you, ma'am.
Okay.
Thank you so much.
Thank you. Thank you, sir.
And Narmada ma'am, over to you.
Yeah, thank you so much. That was such a wonderful discussion. And Brinda, if you have got the note from Dr. Bala sir, I'm very sure you're going to do very well in your exam. And having to hear, last two sessions I've been fully involved in the postgraduate class. I've been thinking what a wonderful opportunity it is. The first time we ever get to meet when we were postgraduates is to see the examiners. And for you, it's a wonderful opportunity to meet such an extremely talented examiners like Zulfikar sir and Maniram sir, so that you will be all well prepared. And really thank you, Bala sir, for chairing this session, as well as Kritika and Prasanna for making sure that we have a wonderful session. Thank you all the participants for joining on this platform. This is itself such a wonderful thing. And thank you, Dr. Somasundaram, for starting off this session, and Dr. Paniraman sir for his excellent inputs. Overall, I think every time it's a very beautiful session. We are really enjoying all that, and hope to see you all again tomorrow for another Wow Wednesday series. I'm sure this will be as exciting it was last week. We have hit 2,400 hits in the YouTube. This is going to surpass this, and it's a very wonderful opportunity for all of you. Thank you, ma'am, for mentoring them, and Vasudha ma'am to mentoring them and making sure they gave us such a wonderful presentation. Thank you, MS Sushant for staying back. Prasanna and Kritika, thank you again.
Sorry, I missed to thank Prasanna and Kritika. So thank you for your wonderful job. Okay, so coordinating with the sir, Sulfikar sir, all the postgraduates, and Paniraman. Thank you very much. See you.
Thank you. See you all next month with the same enthusiasm.
Thank you, sir. Thank you.
Bye.
Thank you, sir. Thank you, ma'am. Good night.
Bye.
Good night.
Well done all. Well done all. Bye-bye.
Thank you.